Hello, everyone. Welcome to Addressing the Mental Health of Cancer Survivors. We're so glad you've joined us today.
Thank you all so much for being here. Happy Friday to everyone. My name is Lauren Milius, and I am the Texas Comprehensive Cancer Control Program Coordinator at DSHS. And our program, along with the Breast Cancer Resource Center, our wonderful partner, has joined to offer this webinar today. We're so grateful to have Dr. Garrett Key here. He is going to be talking about addressing the mental health of cancer survivors. And then we'll have a Q&A session before we close.
As Lauren said, my name is Rayanne Evans. I'm Executive Director at Breast Cancer Resource Center. And I just wanted to quickly share with you that we've been part of the Central Texas community since 1995. And today we have evolved into the organization that we are today. Our BCRC mission services include one-on-one guidance and support services to women with breast cancer, women and men with breast cancer. We have a robust community education and outreach program, of which this program today is part of that, our provider forum. And then we also have a special grant, part of this Centers for Disease Control, that helps us reach out and do this program called KEYS, which stands for Caring for Every Young Survivor, where we really have a focus of services and care on young women with breast cancer and young women with metastatic breast cancer to make sure that we are able to meet their unique needs. I am so pleased to introduce to you all today Dr. Garrett Key. Dr. Key is a board-certified psychiatrist at UT Health Austin's Livestrong Cancer Institutes. He is an assistant professor for the Dell Medical School Department of Psychiatry, and he serves as the associate program director for the Dell Medical School Psychiatry and Behavioral Sciences residency program. And his outpatient focus is on cancer patients. So he is indeed an expert in dealing with this subject. So we're so pleased to have you with us today, Dr. Key, and I'm going to hand it over to you.
Before I go on, I want to make sure that you all get the right slides. So right now, I hope everyone is seeing just the slide and not my notes. Is that where we are?
Yep, you're good. Okay,
great. So there's always it's good to have a disclosure. No conflicts of interest. That mostly I don't have any outside funding, so I can't really be conflicted. And if for some reason I'm not really talking about medications today, even classes of medications, but if someone asks questions, then I'm happy to answer them. And there's a lot of off-label use of medicines in cancer care, so you might overhear some non-FDA indicated uses for medications. And in the next hour, just as sort of an overview of what's to come, I first want to talk about some common terms and make sure that we're using this, these words that are used by lay people and used by clinicians in the same way. Talk a little bit more in depth about depression and anxiety and what those constitute in the context of cancer and more importantly in medical illness. And talk a little bit about the specific concerns of cancer survivors, which is the focus of this talk, but with an audience that's mostly comprised of people who also take care of cancer patients all the time. I think you probably see the phenomenology out there pretty frequently. But I want to touch on sort of the most common themes, and we can talk a little bit about ways to help them. And then I've got what I think may be the most helpful thing is a long list of resources for patients. Some of them are local, some of them are regional, some of them are national. But some places to help your patients to get connected to extra support outside of some of the more formal clinical settings. That I think those are some of the most important things that we have to offer. I like to start. I start a lot of talks that I give with this question when you're talking to people who aren't psychiatrists about what is psychiatry. As I go through this talk, I'm happy to be interrupted if people want to speak and chime in, because I think it's good to ask a question when you're thinking it instead of letting it cool off for 10 minutes. But psychiatry is sort of peculiar because we are this branch of medicine, and we're not named for a part of the body. That we're named for Psyche, who is, you see, it's a Greek's mythological embodiment of the soul. She was born immortal. She got into some fights with Aphrodite because she was so beautiful. Eventually, complex events led her to become married to Aphrodite's son, Eros, who's also Cupid. And then they eventually married and had a child who was Hedone, from whose name we get the word hedonism. But psychiatry decided to adopt her as sort of our, kind of our sigil, and that we study things that have to do with our ability to create and sustain meaningful connections. And so I think that when I try to explain what psychiatry is, this is it. We're this branch of neuroscience that's concerned with our ability to create and sustain meaningful connections with other people. If you think about the things we define as problems, out of control anxiety, problems with depression, psychotic disorders, cognitive impairment, the emotional dysregulation and sort of coping problems that come along as personality disorders, that those all interrupt our ability to successfully connect with the world and the people around us. And so, very broadly, psychiatry is the discipline of medicine that concerns itself with our ability to love and be loved. And I think that's a nice way to wrap it up in a way that sort of makes sense, and I think defines us nicely. So what is a survivor? There are a few definitions of this, but I think the best one is that a cancer survivor is anyone who is still alive and has been diagnosed with cancer at some point in their life. So it could be someone who just was diagnosed. It could be someone who was diagnosed and living with metastatic disease, someone who was diagnosed, treated, now has no evidence of disease and is decades later. Talking about what is coping, it's a common term that we use a lot, and what does that mean? Coping is really the active application of thoughts and behaviors to try and manage distress. Now, as we go along in life, we learn to cope as we're kids and through adolescence, and even really all through life, we have the ability to learn and learn new ways to cope. And after a while, those habits become natural, and they don't always become explicitly conscious, but there's still things that we're doing. Being an organized person, keeping to-do lists, using a calendar, those are all coping strategies. And when new things are added to our load, then we have to find ways to cope with them. And I like this camel picture because this is, a camel who, having seen camels with broken backs from that last straw that you've heard about, has found a very successful way to cope by carrying the load on a cart. But this is sort of, when you're thinking about coping and what's going on, when a person is overwhelmed, that finally, their ability to manage distress has been overwhelmed. When the distress that someone experiences in life, and being alive is a stressful experience. Everyone has to deal with it. But when it becomes more than you have the ability to cope with, more than your skills and organization can handle, then that's when it starts to become disorder. And so distress is anything that's unpleasant psychosocial experience. And you could kind of strike the word psychosocial from that, because anything that you're really aware of is a psychosocial experience. Physical pain is part of this. And you'll see people where when physical pain comes on, that their ability to cope and deal with other things in life is really, exponentially decreased by even, what you might think of as modest pain, depending on how they react to it and how they cope. Depression is a really broad term, and like so many things in psychiatry, what we understand is depression is really descriptive, that we have a way that a person looks and a way a person behaves, and there are brain regions associated with depression, and there are certain biological markers that seem to be associated, but a diagnosis of depression is not a diagnosis of a concrete thing. It just means you have this constellation of behavioral stuff. And I think a good concept to use is when you're dealing with people who have known physical illness, is that depression is when their illness behavior is out of proportion to what you would expect from the illness that they have that you know about. And this has to do with the way that depression, a sick person will withdraw, stop eating, become inactive, tend to rest more, have less social inclination, and also become moody, dysregulated, more tearful. Those are all things that happen when we're sick. And depression is sort of like when someone acts sick, but we don't have another illness to explain it. And when you're dealing with someone who has complicated medical illness, I think that lens is useful. And picking apart what's depression versus being sick, also versus just being sad and grieving. The other major entity that I think is good to be aware of is pathologic anxiety. And that's when you overestimate threats or underestimate how much we can do to deal with them. Now, a sort of common thing, particularly when people are dealing with cancer, is I think there's this question of, whether or not it's common or normal to be depressed after you have a big loss. And that's where I want to draw a line between what's depression and what is grief. And depression is a pathologic state. And when you use this word clinically, you're describing a pathologic entity. Lay people will talk about feeling depressed this morning, and then I saw a friend and I felt better. And that's not what we would use the term depression to mean. When a person's depressed, it's usually really persistent. It comes with, pretty intense feelings of guilt, regret. People feel isolated, which is to mean that the relationships, people that they normally care about and feel supported and sustained by, don't really generate those positive feelings anymore. That there's this sense of aloneness even when you're with other people. There's usually self-criticism. It's comes with hopelessness about the future, sort of a sense of futility about trying to get better, a lack of future orientation, loss of interest in activities and socializing, and it sometimes comes with earnest thoughts of suicide. And so these are not the people who, when they get frustrated, think it would be easier to be dead, and then they take a breath and move on. These are people who start really kind of plotting it out, giving things away, thinking about, really, working on getting to the end of their life faster than they would naturally. Now, sadness and grief are normal, and they're part of loss. And being sick, particularly with cancer in a lot of circumstances, is a very strange kind of forecasted loss, where you can become more aware of what you've lost, and you can see ahead to what you're going to continue to lose by your treatment plan, how long your life will be interrupted, the magnitude of that interruption. For some people who are living with metastatic disease and have a limited lifespan from that, knowing that you won't reach old age is a lot to live with. And that comes out in, periodic episodes of tearfulness and sorrow, experiencing the feelings of that loss. But what it doesn't interrupt is your feeling of connection to the people around you, your feeling of self-worth and integrity as a person. It's an intermittent thing that comes and goes. You still feel hopeful for the future. And I think this is particularly important when you're talking to people who are getting closer to the end of life, that they still can be hopeful for good things during that window and of having good quality of life in whatever there is of life that remains. Their drive for new things will be intact, that they want to prepare and make plans, and they're still future oriented. So when you're thinking about depression, we have these neurovegetative symptoms, which I've highlighted, they're in bold here. And they are, these are the things that are confounded by medical illness. So people slow down, they don't eat, their concentration can be off, they can have cognitive problems, feel tired, and their sleep will get disrupted. So if you're curious about depression in someone who's medically ill, then I would focus more on, and these are kind of the DSM criteria for depression, whether or not they're earnestly thinking of dying. And then I'm going to talk more about sort of suicidality and when it's a problem and when it's not later on. But then also whether or not are they still interested in life, or do they find that they feel guilty and worthless and burdensome more than anything? And those are the things that I look for more as, what indicates depression. So there's and talking about what is anxiety. Anxiety is something that's actually, it ranges from normal to pathologic. And it's sort of a sense of unease about anything in the future that is has an uncertain outcome. So we get anxious about sort of almost anything that hasn't happened yet that's not certain. It's a pretty broad category. Now, there's sort of an optimal anxiety, which is in the middle of this curve. This is, foundational kind of thing in the world of psychiatry and psychology, that Yerkes and Dodson came up with this in 1908. And essentially that you have on the left side of the curve here, low arousal, which is sort of apathy and sleepiness. If you're not all the way awake, or if you have a lot of apathy and a lack of drive, then you don't really perform well on simple or complex tasks. And as your arousal increases, then you start to do better. And this is sort of that middle of the curve is where you're most functional and most adaptive. And then as your level of arousal continues to increase and you start to get, maybe a little more anxious than is helpful on simple tasks like running, or fighting, or something that's really basic that doesn't require a lot of executive function, you'll continue to do better on that to a point and then kind of flatline. But for complicated tasks like planning the next day, planning your future, talking to someone and having a casual conversation, anything that's really requires planning, organization, and high levels of executive function, those things start to fall apart as anxiety goes up. And this part of the curve over on the right-hand side, that's the problem area that you want to watch out for. And that's where anxiety disorders emerge. The way that you'll see anxiety disorders, I think that probably the most common thing that is not always identified as anxiety is irritability and anger. So the patient who you see who's always frustrated, always talking about the inadequacies of our healthcare system, the mistakes people make, angry at you, angry at their family, has a temper, that if you conceptualize them as anxious, you may be able to identify places that you can help them to feel safer and help them to feel more secure, and that those may make real inroads on this outward expression of anger. There's this idea that sort of lingers from, I guess, it seems like in the 1980s and 90s, people talked a lot about anger management. And I remember being taught about anger, not necessarily seeing irritability as part of anxiety as anger. And it really is a much more useful construct, I think, to look at that irritability as an anxious response. But what also comes with it is a blunted emotional range, worry over lots of things that sort of occupies all the headspace you would normally use for planning your life, but also for enjoying things, for thinking about poetry or really listening to a song, stopping to smell those proverbial roses. Anxiety interrupts that and it makes it impossible. That's where the inability to relax comes in. And it also comes out as panic attacks and sort of these really intense episodes of anxiety where people shut down. And those are sometimes related to something like PTSD, but sometimes they're just a little more focused than just someone being acutely overwhelmed. What I left out of this slide is talking about apathy. And apathy is the left side of that curve where people don't do anything. And practically, it's not usually a big clinical problem for a lot of cancer patients. When it comes out more of people who have cognitive problems as either a consequence of their disease or surgical brain injury, some type of dementing illness, that it kind of goes more to the domain of really more concrete neurological problems. And I don't think is something that's very germane to today's topic. So I think it's worth also presenting a model that relates to coping. There's a lot of still a lot of fanfare around Kubler-Ross's Elizabeth Kubler-Ross. She was a researcher who wrote a lot about death and dying and grief, and did a lot of really groundbreaking work around that. And she came up with the 5 stages of grief, which are denial, anger, bargaining, depression, and acceptance. And people sort of learn those as a process you go through and arrive at an end. And really, she was saying you kind of bounce back between them. So a couple of people who I think are Norwegians, Strobe and Schutt, came up with this model, which is the dual process model of coping. And I present it because I think that, again, having a useful frame to understand the experience of your patients, which for all of us will also be our experience because we all grieve, gives you a lens to sort of, understand what they're going through, and also to see what parts of the process are normal and try to direct them to, more adaptive stuff. And really what they put out there is that you oscillate back and forth between loss-oriented parts of grieving and coping, where you are actively missing what is gone. The grief kind of comes in and intrudes in your life where you're not wanting to think about it, but it comes back to you. You also start separating from parts of the past that are related to that grief. And thinking about the loss of a relative, loss of a spouse, I think are helpful here, that people will eventually start to separate out, and old friends and old connections and old activities that belonged to that relationship that doesn't exist anymore will start to fade. And those are painful things, but they're also important in moving forward. Now that's where, the avoidance of restoration changes is part of that. And that's something that helps to modulate the pace of growth and moving through the grief. And those are the restoration oriented life changes where people form new relationships, start to date again, do new activities, find things to replace what was lost. And that is kind of coupled with finding ways away from that avoidance of change, of not wanting to let go, distracting yourself from grief, actively finding yourself that when you're interrupted by it, you're going to get up and go for a run, call a friend, knit, do whatever. And then also moving into new identities and new relationships, so rebuilding a new life and finding new sources of meaning. And as people do this, it's a non-linear thing. And it's, and to a degree, I think it's lifelong, that, you'll meet people and they're 20 or 30 years from the loss of a spouse. I think is just a handy example, but they're long out from the loss of a spouse, but they still remember their birthday and they still have a way of remembering or even celebrating an anniversary. They still remember the day they died and, maybe visit the cemetery or do other kind of grief related work. And that's a little bit of a lifelong tending of the important things in your life and the experiences that you've had. But it's part of how we live through things. You can kind of separate the problematic distress of cancer survivors into three categories. And I realize now I've talked a lot generally about general concepts in psychiatry and how they relate to cancer patients a little bit, but I haven't actually addressed the meat of the question. And there's only a few slides that I have about things that are really specific to cancer patients, but I'm hoping to get a lot of questions, and also if people have either cases they want to talk about or specific places where either what I'm saying rings a bell in a good way or places where it really doesn't seem like it applies. I'd love to hear about that. So the three sort of general categories are people with pre-existing disorders that are exacerbated. So this is the camel that's already overburdened. And then the cancer diagnosis makes it even harder to manage. And I think the vast majority that are people with anxiety and depressive disorders, that you'll see the occasional person with bipolar disorder, the occasional person with, schizophrenia or like a significant psychotic disorder. But generally speaking, I think the vast majority of the times that this will influence your clinical care, it has to do around people with generalized anxiety, panic disorder, and depressive disorders. PTSD also falls in this category. If you have people with PTSD, either from pre-existing non-medical trauma, but particularly people with pre-existing medical trauma, which I think is maybe a little more common than we give it credit for. My perspective is pretty skewed because I see lots of people with medical related PTSD, so I kind of imagine it's out there a lot, but it may also be that where I'm standing shows up a lot for me. The substance use disorders I also would put in this pre-existing category, that sometimes a person who's been sober from alcohol or other substances for a long time gets destabilized by a cancer diagnosis, or if they have an opioid use disorder that's been in remission a long time, but then their treatment requires them to be re-exposed to opioids, that can sometimes reignite things and become overwhelming. So it's just important to be aware and take a good history and try to mitigate that. People with bipolar disorder, they may be destabilized by exposure to steroids, and sleep disruption can also destabilize that. Depending on what's going on with their treatment, they may have to change medicines, which can be a destabilizing thing. And I would keep an eye out for that, but it's much less of a coping problem. I think that it more bipolar disorder is really good. It's like well-diagnosed bipolar 1 is something that responds very well to medical treatment, and so the destabilization of it kind of belongs a little more to problems of medical management, I think. Adjustment disorders are I think probably what most people think of when they think of cancer and distress. So these are people who have coped well through their life and dealt with all of the slings and arrows. And then when they encounter cancer treatment, it's more than they can cope with. The magnitude of disruption in your life that comes from initiating cancer treatment is pretty hard to overstate. Everything changes. You may not be working anymore. You may not be able to walk anymore. You may feel sicker more often than you ever have in your life. You may be in the hospital for the first time. You might be in the hospital for a long time. You could lose parts of your body. You could lose parts of your body that really align with your identity. And there is also an unbelievable level of uncertainty that once you're diagnosed with cancer, there are very few promises that you'll be in treatment for a while, but they're it's not often you could get something close to a guarantee of cure. Even when treatment's been completed, people deal with fear of recurrence and that sort of thing. So the magnitude of the stressor is really big. Adjustment disorders are typically thought of as being kind of self-limited, and that once the stressor resolves, then people usually are able to go back to living well. And that's where cancer is a little bit unusual too, in that the stressor does not always resolve. That you wind up, you may just continue living with it for the duration. Particularly people with either metastatic disease or high risk of recurrence. And then lastly, acquired disorders. So these are new problems that you didn't have. So a person who comes in healthy from a mental health standpoint and then leaves with PTSD. And I think PTSD is probably the main player here. And it sometimes can be really quiet. It sometimes doesn't emerge until treatment ends. That I've seen people that until they graduated out of treatment, it wasn't a problem, but then they realized that they won't be able to go back to the clinic for follow-up visits. And so where you might find PTSD is people who frequently reschedule at the last minute, people who just are lost entirely, people who sometimes if their appointment runs late, they'll leave the waiting room because they can't stand being there very long. Or when you're talking to them about their treatment, that they may have just intense tearfulness and intense affective change sort of out of nowhere, talking about one aspect of their treatment. And then they may also talk about outside of life, outside of treatment, having a hard time returning back to normal life, that they're angry, they're irritable, they don't really imagine the future anymore, that you get this very narrow kind of stuck in fight or flight mode type of thinking about the world that sort of bends your arc away from growth and development. And the good thing about PTSD, it responds really well to talk therapy and it responds really well to medications. So those folks can recover, but they need to be identified. And then I want to talk a little bit about anatomical changes, and it's not exactly body dysmorphia. So people who think that their body doesn't look right and they want to change it and will pursue that. And when everything looks normal, that's sort of the typical body dysmorphia. And for some people, they just struggle to adapt to the post-surgical changes. Sometimes it's just an abdominal scar, something minor. I would say the most common thing is women who have lost one or both of their breasts because of a need for mastectomy. And that is something that's really difficult to deal with. Talk therapy can be helpful. Peer support can be really helpful for that, connecting to other women who have also had to live through the same thing, and really trying to problem solve on specific ways that it interferes for them. For some people, they feel okay, but their partner does not, and the relationship problems kind of ensue for that. And for other people, they can't see themselves, and their sense of body integrity is so closely tied to their sense of personal integrity of who they are, that it's really hard to redevelop a sense of meaning and to kind of reconstruct a sense of themselves without being complete. This also is something you'll see in people who have to lose a limb from sarcomas and osteodiseases, whatnot. But I think far and away, mastectomy is the one that produces that. So, all right. There's a couple of things coming in the chat. And Lauren, I see something here. You were going to answer the question about developmental discussions, talking to children about working with children who have cancer, and also I think maybe parents of kids with cancer.
Yeah, I marked that as something you can answer live, and you're welcome if you feel like it's appropriate to answer that now, or we can hold it until the Q&A, whatever you would prefer, Dr. Key.
Maybe let's wait till the Q&A.
Okay, perfect.
Okay. So common themes for survivors, and these I don't think are new, will be news to anyone. There's no huge secrets here. Definitely the far and away the most common one, I think, is fear of recurrence and death. And to the degree that I see a lot of people who have, sort of grade stage 2, stage 3 disease, and they know they have a high risk of recurrence, and it just racks them. Every time they go for a scan, they worry, they don't make plans past their next scan, and kind of live their life in installments. And it's not a universal rule. Some people do well with it, but we as people, we're like built for certainty. We're, I use the term allergic very loosely, but we're kind of allergic to the unknown. We like to know what's up. Evidence of disease is very different than cured. And people are aware of that. And I even see a lot of people who, once their cancer comes back, will tell me that they have a very different set of feelings, but that anxiety is much better. And they're like, I don't worry about whether or not my scan's going to be bad now, that I know I have a plan, I have to do something, that it was so hard just to sit and wait for cancer to come back. I'm like, can I just take more chemotherapy? Like what, there's nothing to do. And that helpless feeling is very hard to sit and live with. The treatment vacuum is a term that refers to, I've heard people say that the party ended, which I think is a funny way to describe your cancer care experience, but that there's all these people around, they're getting calls, they're getting support, friends know they're in treatment and are bringing meals and helping with childcare. They go to the clinic all the time, they get blood draws, they're taking medicines, they're getting scans. There's just all this attention on taking care of their illness and taking care of their body. And then a whistle blows and it's like, I'll see you in 3 months. And that's very, very hard to feel like nothing's being done anymore. No one's minding the shop. But also there is a very weird type of social network. It's not that weird. There's a social network that develops around all these people who care about you and are working to ensure that you're healthy and taking care of your well-being. And then there's a point at which they go away because they're not clinically indicated anymore. And people miss that. And they feel sort of lost and out in the world alone, and that it's a source of anxiety and distress. Isolation and socialization. Treatment usually breaks up your social network. That just, if you're out of work, you don't go to parties as much anymore because you don't feel good. People don't come by as often. You withdraw a little bit because you're managing your illness. And when treatment ends, those connections are not restored simultaneously. That whatever was lost and abandoned during treatment has to be rebuilt. And while you've been gone in treatment, other people have been living their lives and filling up their dance card. And so it's hard to re-enter. But people also find that what meant something to them before treatment, they don't always care about anymore. And the sources of meaning in their life and the things that they think are most important may have shifted. And I've heard so many people talk about how insufferable it is sometimes to go to a dinner party, because everyone's just kind of complaining about the nuances of school and how frustrating it is to do this and that and these minor things. And in their mind, they're just not there, that they're thinking about larger things, and that they're in a much more philosophical place in life, and that what it is that they value in a personal exchange has shifted. And it produces this weird isolated feeling. It's one of the things people love about peer support and support groups, is that they can talk to someone who speaks their language. And I think for many people, it's a surprise to see that shift. And they finish treatment and they go back and they're like, I don't feel like I'm back to life. I feel like everything's different now. We talked a little bit about body changes and adaptation deficits. Those I think are a little bit intertwined. Body changes are everything from mastectomy to loss of androgens from either, for men, prostatectomy is probably the bigger problem. Younger men who have orchiectomies tend to still, they usually still retain one testis and don't have as many of the big changes as women do from having to go through oophorectomy and surgical menopause, and the implications of that, when you're younger, relate to, sexuality in your 30s and 40s or 20s if you have really, cancer really young, reproductive concerns, and, and just, sort of a sense of, loss of womanhood, loss of completeness are a really big deal. And then for older women, it still is a big deal that I have not yet found that there's a time that anyone's happy to see their sex life end. It doesn't seem that there's an age that's something everyone's fine with. And it happens for both men and women related to, for cancer treatment in big ways. And adapting to those changes, I think, is socially and personally really difficult for people. And then also like people living with chronic pain, having to live either if you're living with chronic malignant pain, problems with appetite, loss of taste, problems swallowing or eating, mechanical deficits that sometimes are there, people living with arthritis, having to take letrozole or other aromatase inhibitors can be really frustrating. And neuropathy, feeling clumsy and numb, or having to live with neuropathic pain that makes it hard to walk and move, that all of those things are, I think, go back to this sort of grieving and coping thing that periodically just kind of sit down and feel it, and then find a way to move on and continue living with what for many people is a new load of suffering. Not so much that what didn't kill you made you stronger, but what didn't kill you left you with some, moderate deficits to which you must adapt. It doesn't really fit on a greeting card, but it seems to be a little more accurate to what the experience of people is. Talked about chronic pain and disability. I think I kind of lumped that in with adaptation to deficits. And then COVID just has magnified all of it. There's not really an end or beginning to what you can say about COVID and how it's affected the experience of people with cancer. But, everybody knows it makes you more likely to get sick from COVID and to die from COVID to be a cancer patient. It's very general, vague understanding we have right now. Somewhat to do with immunosuppression, but there also seems to be evidence that people who have survived cancer and are no longer actively in treatment or having disease, that they still may be more susceptible. It just kind of heightens everyone's fear, makes people more isolated, makes people more alone. It's no good. All right, and young adults are a little bit different. That they have fewer peers. Going to the waiting room is a very strange experience for a lot of the YAs. The young adult age range is 15 to 39. So it really extends, all the way up. This isn't just like tweens. But for them, cancer is a really isolating experience. Socializing is hard. People sort of back away and don't know what to do with you. And then your peers, like your friends at that age, they also probably have never known someone with cancer, and they get a little freaked out about it. When you try to connect these folks to peer support, sometimes nothing ever works about a 35-year-old woman with breast cancer being matched with a 72-year-old woman with breast cancer as a peer support. That their experiences are just very different. The development arc is interrupted. That when you have cancer later in life, not only will you have more peers, but you are more likely done with some of the sort of these basic life tasks of like forming relationships, forming a primary relationship, kind of finding a spouse, starting a family, establishing a career, sort of all this growth trajectory stuff that tends to happen in people's 20s and 30s that you really are, those are years that you really develop and grow into whatever is going to be the next several decades. And when all of a sudden you interrupt that with 6 months or a year, 2 years of treatment, uncertainty, kind of pluck someone out of their social milieu, probably make it difficult for them to continue working the way they expected, and just sort of change that entire arc, it has really huge downstream effects. And those needs of adapting to that and finding mentors and company and ways to not be traveling alone through that is really, really a big challenge. And reproductive concerns are, not just having children, but being a sexual person, how your sex life changes if you're in treatment or after treatment. Both for men and women, it can be just complicated. And even if you have, had a cancer, had it treated, that's still, dating and talking to people, that not everyone is just in a very general way is to run away from someone who's had cancer when they were in their late 20s or early 30s. And it's really challenging for people, and it makes them wonder about when to disclose their status. I've had patients who they've kind of determined they're never going to tell anyone if they don't have to, because it's gone so poorly before. And that's a hard thing to live with. So now that's really the meat of the experience of what it is, the mental health needs of cancer survivors, and talk a little bit more about just a few things about what y'all can do. And the first thing is that I kind of try to remind everybody that I work with, every single clinician, we're all mental health providers. That when someone comes to see you, if you are clipping someone's toenails, if you're draining an abscess, if you're treating a cough, or if you're just listening, then you're going to make someone feel better in terms of their psyche. That, making a body healthy is making a mind healthy. And some of the things that you can do that are really simple and come naturally to most people can really have big benefits for people. Validating exploration of concerns, just non-judgmentally asking someone to tell you more about what they're feeling, to describe to you their suffering, is very therapeutic. It helps a person just to feel heard and witnessed. That there are a lot of situations where we can't fix something, but hearing someone out about it has an effect of unburdening them to a degree, and it helps them to feel better. Normalizing distress, letting someone know they're not the only one. Cancer is really isolating. And when someone says, I know that I don't have cancer anymore because you've told me, but I'm just afraid it's going to come back. And having someone answer that with not like, yeah, I hope you can remember this, but you can say, I hear a lot of people say that, and you're not the only person who feels that way, can help someone to feel much better and really be a huge service to them, and is very simple to do. If you notice that someone does seem anxious or depressed, asking directly about those symptoms and finding your own authentic words to inquire is incredibly helpful, and lets them understand that it's okay to talk about that. And someone comes in and I'm just going back to work, it's been really hard. That's a time to say, it can be really hard. I hear a lot of people say that. Tell me what's hard about it. Do you think you might be depressed? Do you find that your work is less interesting? Are you still interested in visiting with family? Has the pleasure gone out of your life? Are there any things that you still enjoy? And putting those things out there lets them know that that's not a unique experience. It's not a problem that's peculiar to them, and also helps them find words to talk to you about their mental health. And then thoughtfully discussing suicidal ideation. So, being able to ask someone, a lot of times when people are distressed, they think about suicide. Is that something that crosses your mind? May elicit some good stuff from people. But I would be really careful to remember how much people hang on your words that I hear. And in whatever role you have in working with people with cancer, that they remember everything you say, and they remember what you do, and they think about it, and they come talk to me about it. And so I want to remind you of the impact that even small gestures have. I'm going to touch on a couple of philosophical things that I think are important. So related to suicidality, I think we really have a hard time as medical professionals acknowledging that suicidality is not rare, and in the really broadest sense. Albert Camus, he was a French philosopher. He won the Nobel Prize in 1957 at the age of 44 for literature, and then sadly died not too long after in a car accident, returning home from the beach with his family. But he wrote sort of an essay called The Myth of Sisyphus, and he said in it, there's only one serious question, which is suicide, and deciding whether or not life is worth living is the fundamental question in all of philosophy. And I think universalizing that can help us understand when someone says, yeah, sometimes my problems are so big, I just think it'd be easier not to deal with them. And it's very different than I have been taking concrete steps. And that's more of an expression of suffering and distress, and as a place to listen and help a person, look for more meaningful things, that when you have something that outweighs your suffering, then you can live and carry on. And so related to that, thoughts of suicide are not always cause for alarm. That people with cancer, particularly people with advancing disease, metastatic illness, that it's a way of preserving a sense of control, and helps them to feel that in the event of unmitigated suffering and uncontrolled pain, that they still have a way out, that they will not be forced to live through all of the horrors that life could offer. Now, of all the people who think of suicide, only a very small fraction actually either attempt it or complete it. And that's where I think, trying to normalize that and help people be able to talk about it. That to me, it's more of a breakdown in your coping skills. When someone's thinking, okay, well, I have these 18 things to do, I can't do that. Maybe it would be easier if I'm dead, is a breakdown in how you cope. And that's where therapy and time and sort of, breaking bigger, small problems into smaller problems that are solvable helps us to overcome things that we think we couldn't. Thinking about and making plans are really different. And that's where if someone's telling you that they've thought of suicide, that it's worthwhile to ask, well, when you think of it, is it something you're sort of working towards? Is that a goal, is to find a way to end your life? Or is it something that just when you feel too overwhelmed, it just pops in your head? And then lastly, in the United States now, that medical assistance in dying and physician-assisted death are two terms that mean kind of the same thing. They're legal in a handful of states. More places are considering legislation. It's legal in Canada, and so it's something that's really, it's becoming part of the discussion in cancer care. Okay. I want to be careful with my time. So some of the questions that got sent in already were about resources. And so I want to talk about some of the resources that are available for patients. And I think all of these things are without cost, which is great. So first, there's livestrong.org. Hopefully you guys are all familiar with that. They have connection to a really broad range of services for cancer patients, of exercise programs, trying to get people connected to financial resources and navigation, all sorts of things. Peer support, stuff like that. Education for families of kids who want to learn more about cancer. Live Strong at School is a really cool program that you may want to get involved in, to teach kids about the world of cancer care. But they're really just a patient advocacy organization and support kind of whole patient care. But that's a great resource. The Flatwater Foundation is something that's sort of near and dear to me. I sit on their board, and it's an Austin-based nonprofit. And what Flatwater does is raises a bunch of money and then uses it to pay directly for psychotherapy for cancer patients or families of people affected by cancer who would otherwise not be able to afford it. And so I urge you all to remember that as a resource for your patients, and remember it as a source for you to direct your philanthropic urges. I think all of these places use money, you give them great, and I think Flatwater is included in that. It's fantastic. Cancercare.org is another national level organization that has a wide range of support, case management services, education, and also can help with financial assistance for people with cancer. Widowedparent.org, I think, offers a particularly unusual resource that is maybe a place where we've sort of overlooked things, and this is to help a surviving parent who's lost their other spouse. It's based out of UNC. It started off as a support group for fathers who had lost a wife to cancer and had young kids at home. And then they realized that really any single parent due to cancer could use some help. And then they even backed away from cancer, and just really any parent who's lost their spouse can get involved over here. But that's a great resource. Regarding Cancer is an Austin-based philanthropy that's a peer support service where they will match cancer patients with local peers who have had some training in how to support people and volunteer their time to be connected to other patients who have a similar type of cancer, and sort of keep them company and give them support as they go through treatment. Cancer.gov is the NCI's website. It's got lots of different connection to clinical trials and resources. It's a little bit more clinical. It's got lots of information about diagnosis, staging, information about advanced cancer. But you can see down here, there's a little coping section, and that has some psychosocial resources there, some things that that people can read about. But it's a pretty good resource. Cancer Advocacy is a national coalition for cancer survivorship, and it's the oldest survivor-led advocacy organization in the country. And they're sort of a federal level organization that advocates for quality cancer care and empowerment of cancer survivors. Also, another good resource. Caringinfo.org is a national hospice and palliative care organization that helps with a lot of end-of-life planning, talking about understanding palliative medicine versus hospice, advanced directives, a little bit more of nuts and bolts of living with an advanced illness and preparing for the future. But that's something good for people to have resources they can explore, because you can spend a lot of time on that and it's hard to get it all done in an office visit. Camp Kesem is a summer camp for kids that I think it's from ages like 6 to 12, maybe 6 to 15, for a kid who has a parent with cancer or has lost a parent to cancer. And this is a place where they can go and meet other kids who have lived through some of what they've lived. I do see someone was asking about cancer patients, whether they serve undocumented populations. I think, to my knowledge, I think they all do. I don't think any of them, they don't really deal with insurance, and all their services I think are generally free of charge. And I think that they do serve undocumented people. I'm realizing now something that I'm remiss that I did not include is Wonders and Worries, which is another Austin area of philanthropy. And they provide services for kids and families where one of the parents is affected by a serious illness. So that would include cancer. But they're a wonderful resource. They do incredible work. And they're here in Austin. So I would definitely keep them in mind. There was a question about services that focus on minority populations. So the AABCAINC is their domain name is kind of complicated, but that's the African American Breast Cancer Alliance. And this is a great resource. I think, breast cancer being so common, and being, I think, a little more complicated for women of color, that there are lots of barriers to access to care, and there seem to be some pretty significant outcome differentials for women of color with breast cancer. And I think that this is a great resource. There's Latinas Contra Cáncer. This is another great philanthropy for Latina women who are dealing with a cancer diagnosis, and particularly good for us here in Central Texas. And lastly, cancernetwork.org is the national LGBT cancer network, and helps to connect patients and provide resources for the queer community who are also living with cancer diagnosis. And one of the things that I think is particularly special about this, a really common complaint and a common problem for people non-binary sexuality, is that they have a hard time finding providers that they feel like are understanding, and that they can form good connections with. And this website helps to connect people to physicians and practices where people feel like they have been made comfortable. And so I would definitely keep that in mind as a good resource. I like to close with some sort of philosophical thoughts. When you're thinking about your cancer patients, I think of this often, which is a quote from the Wailers, and this is distinct. So in the middle here, this is Bob Marley. You got Peter Tosh over on the right, and then Bunny Wailers on the left. And this is what Bob Marley looked like in 1966, which is way different than what he looked like in 1970. But I think this quote to me sort of embodies that when a person is complaining to you, they're suffering, that they're the expert on it. They're the person who knows how much they're impacted, and they know what they feel like. And that it's important to listen to them without trying to put your own values on it, and to hear their complaints as they're complaining to you. And from there, you can help the best. And this is, what I use to try to not compare apples and oranges, that one person with a serious illness that's clearly got lots of pain and a poor prognosis, and they talk about their suffering, and it's easy for me to slide into a place where I don't consider the suffering of a less severe disease to be of equal magnitude, but it is. Each person's measure is their own. And lastly, no discussion of I think living with cancer is complete without referring to Elizabeth Kubler-Ross, and that in order to get comfortable taking care of people who are sick, people who are potentially dying, is to be really comfortable with our own ideas about mortality and illness, so that we can sit and listen without feeling anxious and without our own thoughts interfering in our ability to help them. So I went a little bit long, and I hope that we still got some questions and that people are still awake out there. and would open it up for questions now.
Anna asked about addressing the topics, the implications of diagnoses, the psychological toll, and other existential questions at different stages of development. And so I know that you spoke specifically to young and adolescent adult patients, but I just wanted to see if there was anything else you had to add to that.
I do. I actually talk a lot to my patients about sort of existential themes and kind of pulling apart this mess of, I just don't know what to do anymore. I'd be like, well, is it about isolation, meaninglessness in life, concerns about death and dying, or like your ability to live autonomously and like choices and guilt and stuff like that. And I feel like that lens is really helpful. And thinking developmentally about what are the tasks of a person's life at a certain stage. If someone's 17 versus 25 versus 50, kind of the ways that you're supposed to be living your life and what your sort of cohort goals are developmentally, I think really can inform how you talk to them, what the problems are that you are trying to focus on, to help them, stay close to that more typical arc, and to kind of get back on the bus with everybody else, and then also to find ways to sort of understand what they may have lost. That a lot can come from just finally being able to put a name on your losses and acknowledge them, can sometimes be a big part of moving on.
Thank you. We're going to do one more quick. So we'll see if we can give like an elevator speech for this one. So last question that came in was, how does financial instability affect the mental health of our patients? Do you feel it is difficult to address the mental health completely when someone is not able to meet basic needs?
Yes. So I spend a lot of time in the hospital here at Del Seaton, trying to treat someone's depression when they have been homeless for 10 years. And the things that you can do most for someone in that circumstance is to make sure they have secure food and a place to sleep. That it's just really hard to work on higher order stuff when someone's basic needs are not met. And cancer, there's a whole area of study on the financial toxicity of cancer treatment, and that it, takes people out of work, harms their ability to earn in the future, harms people's future employability. Even if they're well, when they tell an employer that they had cancer a few years ago, they kind of get knocked down the pile a little bit. It's a problem. Yes, and negatively is the the most complete answer, is that it's very harmful, and is a huge part of trying to help people. Is just covering basic needs is a necessary thing before you can start working on self-actualization and higher order stuff about your life.
Thank you so much for joining us today. Thanks again to Dr. Key for your insight and expertise. And I hope everyone has a wonderful weekend. And thank you for all the work that you do for cancer patients and survivors.
Great. Thanks for having me. And if people send questions, I'm happy if you forward them on to me and try to answer as best I can.
Awesome. Thank you so much. Thanks, everyone.